did look like the arm that with the COX inhibitor, patients did do better. But that needs to be verified. There is a light over there, and it does look important. But as you say, there are side effects, and there's been a lot of side effects with the COX-2 inhibitor. So just to prescribe it, and to say, well, it may help, is not correct. Yeah. And yet there are other people that believe that the carcinoids, the vitamin E derivatives, are very anti-inflammatory if taken in high enough doses, so that could work as an anti-inflammatory drug. And then, of course, there are other people that believe that if you just give indomethacin, and it would be standard of course if you were in Norway, that you'd get that type of a drug. That all patients losing weight that have got signs of inflammation should get it. But in North America, it's certainly, besides the EPA, not being a standard.
So that's the 3 omega fatty acids.
Yeah.
When you say EPA.
Yeah.
Well, then you raise the nutritional versus the pharmacological modification of inflammation. And there are a number of antioxidant nutrients which suppress inflammation, such as the antioxidant vitamins, but particularly E. And then you have the omega-3 fatty acids. And extending beyond that, you've got all sorts of other classes of nutrients that patients with cancer and wasting and malnutrition might be deficient of. It's useful to think about this. We talk about nutrition as having the possibility to alter a process like inflammation. But you also need to understand nutrition as providing the building blocks for the construction of tissues. So you can hope for someone to gain weight by making them less inflamed by giving them a small quantity of a vitamin. But how can they build this tissue unless they have enough energy, protein, and constituents that range from creatine to choline to make the membranes, the myofibrils, all the things that you wish the person to retain or build within their body.
The hormonal milieu. You need the correct hormonal milieu to be able to build in the right way.
Can you explain that?
Well, that's why certain of the androgens are now being thought to be playing a big role. There's some people that think there's a new drug, the selective androgen receptor modulators, testosterone, which we know can build muscle. And there's some people around the world that are giving testosterone to all elderly patients that are frail and elderly that have a very similar pathogenesis, which is probably increased inflammation. So oxandrolone, which is an anabolic steroid as well. So the hormonal milieu seems to be playing a role as well. You need all of those things. You need the nutrients, you need the hormonal milieu, you need the inflammatory state under control in order for the situation and the milieu to be ready to build.
So can you comment on the current state of evidence in terms of nutritional supplementation as to what a clinician in practice who may be tuning into this podcast or podcast, what would you say to a clinician in practice in terms of what nutritional support should be?
I really think before we get to nutritional support, because this goes back to your question as well, I think all patients into a cancer clinic should have a nutritional screening done.
Assessment.
And a nutritional screening. And if you look at the American Society of Parental and Enteral Nutrition, that's what they actually recommend. All patients should have a nutritional assessment done. And if we look at some of the results and some of the evidence by Paula Ravasco, where she took patients with colon cancer and she randomized them to either receive a nutritional assessment or to receive a nutritional supplement or to receive nothing. And she showed statistically significant improvement in quantity and quality of life in patients with colon cancer, and then went on and showed it in patients with head and neck cancer. So it does seem that personal interaction of probably what foods do you like, when do you like eating the foods, how much of the food can you eat, does it make you feel nauseous to eat in the morning, does it make you, what about the evening, do you like people around you, which are the foods that turn you on, which turn you off, all of that assessment seems primarily We know now that's irrefutable evidence that it works for patients to live longer and to have a better quality of life. As far as the nutritional supplements, in those trials, the nutritional supplements were better than nothing at all, but they weren't as good as the actual dietary consultation. So I think there's a lot of nutritional supplements around, and we are looking at some of them, and some people do claim that some work better than others, and some work a lot and some don't work at all. But I don't think that at this stage there's hard and fast evidence for a particular nutritional supplement to be regarded as the standard. I think if a person is eating adequately, and you've maybe selected that they're not getting some or other nutrients, the other one that we know now is better for patients with cancer is vitamin D. Because the evidence is there that those patients that have got low vitamin D levels, and it seems now across the breast cancer, colon cancer, they do worse. Their long-term outlook is worse if they've got low levels of vitamin D. So if you could increase the levels of vitamin D of the patients, you probably improve a lot of other things. And in the Northern Hemisphere, this is a problem.
Yes.
It is a problem.
Interestingly, I'm involved in a study looking at falls in cancer patients, and we're measuring vitamin D as a risk factor for that. And I would think, following on from what you say, vitamin D deficiency certainly would mean muscle wasting and a higher risk of falls.
You ask where the evidence is, and I think about it this way. What do you hope to achieve by supporting cancer patients who are losing weight? You want them to maintain or gain body tissue, but particularly body tissue, tissue in the lean body mass, muscles, and you want them to gain by that physical function, amongst other things. There's a great body of evidence that starts out with normal, healthy people, and this is the research literature on adults who have the intention to do physical activity or sports performance. And this is a very rich resource from which we understand that in order to have this improved performance and improved body condition, what you need to have is you have to have nutrients in the right mixture at the right time, and those nutrients are directed to the sites and processes in the body we want them to be by hormones, which have to be optimal, and androgens, for example, are really important for that. Being sensitive to insulin is really important for that. And the activity, muscular work, is really important for that. So we feed the person, drive those nutrients by hormones, by physical activity into the tissues where they accrue, and allow the performance and function and well-being that goes along with those things. So the principles of that and the evidence for that are already very strong in that context. The next place where there's lots and lots and lots of evidence that is of high quality is in the elderly. So old people with without any known complicating illness, just in progressive aging, are losing weight, developing a poorer nutritional status, and alongside of that, losing physical and other functions. So people have come forward to them with what they learned from normal healthy people and have applied those. And there was a rich resource of randomized clinical trials that demonstrate if you take the 90-year-old man and correct his perhaps hypogonadal status to bring him up to a young fellow's levels of testosterone, put him in a training program with resistance work, particularly, so like weight building, muscle building type activity, and provided a diet which has sufficient energy, protein, vitamin D, and vitamin and all the other classes of nutrients essential, then there are very substantial benefits in physical performance, quality of life, survival, immunity, many, many positive outcomes. What Martin's alluding to, I think, in speaking about Mantovani's trial or some things that we all know to be going on in the background, is that it's the next step forward is the application of these things in people with chronic illnesses. So to go beyond the elderly into the wasting and cachexia syndromes. And there's only half a foot in the door. There's not a lot of evidence, but it's being acquired. And there's every reason to believe that the fundamental principles apply to people who are wasting because they have cancer and other diseases.
So what sort of outcome measures should we be looking at then in terms of studies for whether it be nutritional supplements or whether it be medications such as non-steroidal anti-inflammatories or other agents? What sort of outcome measures should we be looking at in the advanced cancer population?
Weight is the one that people always use, but gain of weight may not be the aim either of individuals, and that gain of weight is not the be-all and end-all of endpoints. This weight gain or the outcome of treatment has to be connected with function, well-being, activities of daily living, tolerance to chemotherapy, resistance to infection, and other outcomes. Ideally, you want to aliment and support someone metabolically so they spend less days in hospital or are less likely to fall down. All of those things are legitimate endpoints.
You mentioned the C-reactive protein earlier on.
Yes.
Where does that fit in? If you're supplementing someone, giving someone dietary supplementations, you're using a pharmacological approach as well, would you do serial CRP measurements? I don't know what it would be, once a month, whatever. If those are, is there a correlation between that and what's happening in terms of cachexia? So is that an indicator or a surrogate indicator of what is happening? Does that tell you, well, maybe stop, as the disease advances and maybe becomes very advanced, is that an indicator to perhaps stop that approach?
I would wish, as we all would, for a blood test that would mean everything.
Yeah.
I think it's useful to identify people who have inflammation and manage it if possible, but...
Is it predictive or is it prognostic? The CRP. That, I think, is the big question. And is it predictive of a bad prognosis? Bad prognosis? Well, it may be.
But it may not be, and it may not be.
It may
so
not
in that
be.
case,
It's
you
quite
can't use it in the
right?
way that José is hoping for.
We don't have, the bottom line is we don't have a foolproof surrogate.
Okay, so we mentioned nutritional supplements, right? We've spoken about some pharmacological therapies that we could look at. We've spoken, and included in that were the 3 omega fatty acids,
So those would be nutraceuticals, as we call them. Nutraceuticals.
Right, so the term is nutraceuticals.
Yeah,
right?
it's not a pharmacy.
From a pharmacological perspective, what is available there that we could consider?
Well, I think that there are a number of things that one can consider, but I don't know